Hey, good morning. Can you hear me, Shaimaa?
Hi, good morning, Corey. Yes, are you able to hear me good?
Yes, sounds great. Loud and clear.
Okay, great.
So let's see. We got some people starting to log in. I'm sure we'll have more trickle in. Another minute. Get started. With this topic, maybe there will be a lot of material for some discussion afterwards. So even if you end a little bit early, I think it'll be good to leave you enough time. So good morning, everyone, and welcome to our weekly CMR conference hosted at VCU. Really excited to be joined by Dr. Shaimaa Fadl this morning. She's an assistant professor in radiology here at VCU. And she's going to be touching on the use of CMR in patients with heart transplants. And this is sort of the patient population we see somewhat frequently, and so I think is a really important concept to go through. Just a reminder to everyone that these sessions are CME and MOC accredited, so don't forget to text the code on the screen to the number provided. And today's session is also ASRT accredited, so if there are any MRI technologists in the audience, make sure that you claim credit as well and are individually logged on with your Zoom so we can verify some attendance. And with that, we'll go ahead and turn it over to Dr. Fadl. Thanks again.
Thank you very much, Corey, for the introduction. Good morning, everyone. It's a great pleasure for me to talk today. And I'm going to talk about MRI in heart transplant patients. We are going to touch base about the expected post-transplant cardiac MRI features, discuss some complications, and discuss some cases of post-transplant, post-heart transplant. In general, as a background, around 5,000 heart transplantation performed annually. 12.6% experienced rejection in the first year of transplantation. Endomyocardial biopsies are seen, is done a lot in these patients, and complications can happen around 3%. Plus, you have the risk of sampling and histologic errors. Hence, there is a rising role for cardiac MRI. If there is a way that we can avoid at some point the endomyocardial biopsies or decrease them. Let's start by talking about the expected post-transplant appearance. Regarding the anatomy, there is some ways, older ways of doing the transplant. This is a biatrial method, like the anastomotic sites will be at the left atrial and right atrial level, and arterial plus the arterial anastomosis of the main PA and the aorta. This is associated a little bit with arrhythmias risk because of the high risk it is close to the SA node. So there was another suggested method, which is bicaval method. Bicaval means that there will be anastomosis will be happening around the SVC and IVC side at the atrial level. And then the atrial level along the left atrium, there will be a residual cuff tissue of the native left atrium where the pulmonary veins are inserting. And then they will place the donor left atrium on top of that residual cuff of tissue. And then, of course, the anastomotic sites at the PA and aorta levels. Sometimes you can, instead of leaving just a residual cuff tissue, you can leave unblock pulmonary veins, but this will require a high surgical technique for this process. So the most commonly method performed is that bicaval method with the left atrial to atrial anastomosis. Why we care about to decrease the number of endomyocardial biopsies, because they found that complications can happen in 3 to 6% of the cases, plus the sampling error, histologic error. You need to go by the biotone through the jugular vein, all the way through the tricuspid valve, and then go and take a sampling through the interventricular septum. This process is very multiple, especially during the first year post-transplant, and can cause some damage to the tricuspid valve leaflets. And so many patients may have some tricuspid regurg. The reported prevalence of tricuspid regurg ranges from 47 to 98%, and is considered moderate to severe in 30% of those patients. And this is a patient, post-transplant patient, and this is the expected anatomic appearance in those patients. Starting with the axial semi-steady state free precession, there is a left lateralization of the heart. So left lateral positioning of the heart. This is a normal expected appearance. Sternotomy wires will, indicating the prior surgery will cause some artifact. Additionally, you will see the elongated appearance of the left atrium. In some patients, you will feel that the patient may have double left atrium appearance. This is not a true enlargement of the left atrium. This is a little bit the native left atrium that have the residual cuff of tissue that have the pulmonary veins insertion. And on top is the left atrium, the donor left atrium anastomosis. And this is, you will see some just caliber change of the pulmonary arteries at the anastomotic site, as well as the aorta. And this is the post-contrast T1 vibe. Let's scroll and see if this is the appearance that we would expect. Yes, this is the left atrial elongation or morphology. And then you have, look at the pulmonary artery, you will see like a waist-like location or caliber change because of the anastomotic site. And at the same time, this waist-like appearance in the aorta. Note that there is no outpouching, there is no abnormal configuration of the arteries. And scrolling up, you will see also caliber change of the SVC near the anastomotic site. Note here, it's different caliber of the SVC when compared to superiorly because of the anastomotic site. Knowing the expected will let us realize what's unexpected. This is a 71-year-old man, had a heart transplant in 2010, and MRI was done in 10 months later for suspected aortic abnormality. Scrolling, you notice that there is some left pleural effusion. Scrolling more superiorly, there is abnormal configuration of the aorta caliber here. Like there is like an outpouch along the right posterior lateral aspect. So looking more at more images, this is a cine images sagittal view through the aorta. And there is like a focal outpouching from the aorta with, and it is filled with blood material. And this is the axial cine at the same level, showing that wide neck and focal outpouching concerning for pseudoaneurysm. And this is a post-contrast T1 vibe. And again, it shows that focal outpouch. And it is along the, near the anastomotic site. Like this is the waist-like appearance of the anastomotic site. And below it is the focal outpouch. And the angio confirmed that finding. All these findings are concerning for pseudoaneurysm. And this is the volume rendered image showing that focal outpouch. So we are done with the expected anatomic changes and how to realize the unexpected findings. How about the structural changes? If there is expected changes in the tissue characterization or parametric mapping of the transplanted heart, for the trainees, just remember that T2 is a surrogate. We use it as a surrogate for edema and inflammation. T1 mapping reflects the changes in intracellular and extracellular compartments, and the ACV values are used to reflect the interstitial expansion. This patient with a heart transplant, you notice that there are some elevation of the T2 values, and also elevation of the T1 values, like the T2 values are ranging 57, 47 in some areas. And the T1 values is like 1600, 1755. In a study done by Dolan and his groups, they wanted to see the impact of the donor recipient changes, characteristic changes, if will affect the MRI appearance of the heart transplant recipients. So they evaluated 58 heart transplant recipients. And they concluded that if the females are recipients, there is increased pre-contrast T1 values relatively. If there is recipient donor differences in age, weight, and body mass index, there is significantly associated with elevation of ACV values of the transplanted hearts. If there is hypertension in donors, will still result in increased ACV values. Like they found that patients with hypertension have higher values, like around 31% plus or minus 4, compared to the hypertension negative, either global ACV or peak ACV. Both are elevated in hypertension positive donors. Again, increase the age of the donor, also associated with elevation of the MAPS, T2, and ACV values. Also, it will lead to, it's correlated with diastolic dysfunction as well, but we don't measure the long axis velocities on MRI, but can be seen on echo. Okay, and then there was the second question. Are there certain values or cutoff that they use in the parametric mapping on CMR that consider normal range after heart transplant? And few studies suggested some cutoff for their evaluation, but most of them are on 1.5 Tesla. And on 1.5 Tesla, you have higher T2 values compared to the 3 Tesla. But again, it's vendor different. It's different from an institution to another. It's depending on the setting for every institution. And they suggested that the structure of the transplanted heart will have some elevation of the values compared to the controls, like elevation of the T2 and native T1 values are usually elevated compared to the control group that of the patients. They found that the T2 values, they were, the ranges was 50 plus or minus 3. And the native T1 compared to the 55.7, and the native T1 values were elevated 1,037 compared to 993. These values are elevated, but most of the cases were from 55 to 59 compared to the group where it is regarding the T2 values, you have elevation compared to the T2 values where it's 45 plus or minus 2. The T1 values here, again, around the 900, and here it's above the 1,000. And regarding the ACV was not that elevated, except in just three segments, which is mostly the basal segments. One of the basal segments and 2 of the apical segments. So just the ACV is the one that was not that elevated in all the segments, like the T1 and T2 values. Knowing that, let's talk a little about the post-transplant complications and the role of the cardiac MRI in those patients. We are starting with rejection. We have 2 types of rejection, the acute cellular rejection, the antibody-mediated rejection. They are, these rejection is really, patients experience 12.6% of those heart transplant patients experience rejection in the first year of transplant, but this value is getting down over the time. And while they are after the first year, these, the percentage or the incidence of the rejection decreases over time. Despite that, the vasculopathy or cardiac allograft vasculopathy increases, risk increases over time. Starting with acute cellular rejection, where the lymphocytes attack the myocytes, they classify as 4 grades, grade 0, 1R, 2R, 3R. Grade 0, when there is no infiltration, just normal myocytes. Grade 1R when there is interstitial or perivascular infiltrate. And usually the immune suppression decision is not taken based on 0R or 1R. 2R is when there is at least two foci of infiltrate, two or more. And 3R is when there is diffuse infiltration and multifocal myocyte damage, hemorrhage and vasculitis. The antibody-mediated rejection is when there is antibody like rejection against the cardiac myocytes and donor donor antigens, and as well it can be classified 0, 1, 2, 3, and 0 it's negative, but this antibody-mediated rejection is based on the positive histopathologic findings and immunopathologic stain as well. Grade 1 is when there is either one of them is positive. Grade 2 is when both of them are positive. Grade 3 when there is severe involvement and damage, interstitial hemorrhage, capillary fragmentation, and edema. How about if there is this paper is a meta-analysis about the CMR in patients with cardiac transplant rejection, and they concluded that quantitative T2 assessment is the highest diagnostic quality, diagnostic accuracy, followed by T1 and ECV. So that meta-analysis is suggested that the quantitative T2 is usually highest diagnostic accuracy. It's more accurate for detection of rejection, and then it's followed by the other parameters. The LGE was not used as for the diagnosis of rejection, but it carries a prognostic information. Like it is helpful in prognosis, but the presence of LGE does not mean that there is rejection or acute rejection. The T2 maps, in other study, they suggested that the basal T2 mapping combined with the ECV is the best diagnostic accuracy, like when you measure at the basal segment, and when you combine the T2 findings and the ECV values, you can decrease the need for endomyocardial biopsies by 50%. Like they used that algorithm. They included 27 patients. They started with T2 mapping. Patients with T2 higher than 57 on 1.5 Tesla, who went to endomyocardial biopsy. They got there was diagnosis. Most of the patients were diagnosed by rejection, and one patient was not diagnosed by rejection. And then patients who were less than 57 milliseconds on 1.5 Tesla. They looked at the ECV, and patients with higher ECV than 32%, those patients who went into endomyocardial biopsies, and some of them, 50% got rejection and non-rejection. And the other patients, they avoided the endomyocardial biopsies who have low T2 values, like relatively low, it's 57, and lower ECV values, less than 32%. In summary, for that algorithm, means that with T2 and ECV, when they are elevated, combined together, they didn't miss any rejection. So all rejections were detected, but of course there was some of the patients were no rejections. So 7 patients were detected rejections, and 3 was a false positive, no rejection. In another study, Osman and his group, they put a cutoff. So the range that usually the studies are putting are between 55 to 59 on 1.5 Tesla. And let me move that box here, maybe. So this study, they put a cutoff for T2 as 56.2, and they looked at all the rejections here, that light blue color. That clinical rejection is the orange color, and the AMR, the type of rejection, and this is the 2R and 3R grades of the acute cellular rejections. And they found that when there is a rejection, these values are elevated. It's above that cutoff of 56.2. And they found also that T2 map values decreases with treatment. So, and they suggested that T2 quantification carries prognostic value regarding the rejection and higher grade of rejection. The higher the T2 values, the higher the grade of rejection. Let's start with that illustrative case about rejection. This is a patient with who was 26-year-old lady, 2 years post-transplant, was admitted with suspected rejection. And then she was treated with empiric steroids, IV immunoglobulins, and plasmapheresis. And this was the cine images in short axis. And it shows that the myocardium is relatively hypertrophied. There is abnormal signal like a ring-like morphology around the epicardial and mid-myocardial with a relatively dark myocardium along the inner surface of the heart. And in LGE images, there was some enhancement at the areas of the abnormal signal intensity along the anterior, septal, inferior wall, and it is relatively subepicardial and mid-myocardial pattern. T2 values were elevated on 3 Tesla. It's 56 to 65. Like this is, if we looked at the base, this is 56, 63, 65. And on the T1 values were elevated like 1600, 1600. It reaches 1700 in some areas. So let's review what happened to this patient. Day 0 from the hospital, the patient was suspected to have rejection, antibody-mediated rejection. And she was treated by empiric steroids and IV immunoglobulin and plasmapheresis. In day 12, CMR was done, and it showed the high T2 and T1 values. In day 53, the patient, and then the patient was, before that, between 12 and 53, the patient was, the biopsy was done, it was negative, and the patient was discharged. On day 53, surveillance showed the antibody-mediated rejection suspicion again, and the patient was readmitted for therapy. And her regimen at that time intensified to include the bortezomib and eculizumab. And after that, there was a repeat of the cardiac MRIs. Note the values has decreased, the T2 values, that range, that higher range became down to between 45 and 49. And that T1 values between 1600 and 1700 got down to 13 to 1400. This will indicate or suggest that T2 is can be reflective to the presence or absence of acute rejection, at least T2. And then there was more recently in the literature, the question about can CMR used for surveillance of rejection instead of the endomyocardial biopsy? And this is a really valid question. Can we use it? Still, more studies need to be validated. But most of the studies, in this study, they evaluated 401 cardiac MRI studies. Multiple biopsies was done in 40 heart transplant recipients. And they found that there was elevation of the T1 and T2 values in patients with grade 2R cellular rejection, acute cellular rejection. At the same time, the T2 elevation here was higher, if you notice here, is higher, like 59, above 59 in patients with 2R rejection. Like these are the values in those patients with the grade 2R rejections. The values of the T2 values are like elevated. Maybe this is 59 cutoff or something. So, but they concluded that it's the use of multi-parametric assessment, like the T2, the ECV, and the T1 values is having greater specificity and negative predictive value. At least they will not miss the rejection. Rather than if you used one parametric value alone, like T1 alone or T2 alone. And they suggested that the non-invasive cardiac MRI surveillance in acute cellular rejection in the first year is feasible, can be done, compared to the endomyocardial biopsy-based surveillance. Some of the patient will need like 10 endomyocardial biopsies in the first year. There is a role for the delayed gadolinium enhancement. Yes, delayed gadolinium enhancement can be seen in many patients, particularly like around 18% in one of the studies. But the pattern is really variable. Like most of the pattern, like 41% is non-infarct pattern, like in this patient. Some of the, like it will be random or subepicardial and mid-myocardial. In some patients, for some reason, I find it's ring-like morphology. And some, like in 37% of the patients will have like infarct pattern. And some will have both, and 22% will have both patterns. It plays important role in prognosis in terms of although it is not indicative of acute, like most of the studies does not significantly correlate that with the presence of acute rejection, but they correlated with, it is associated with long-term risk of death or major adverse events, cardiac events. So it has been linked to bad prognosis. Now, we will like touch base on the vasculopathy. The acute cardiac rejection starts at the first year, and over time, the risk decreases, but the vasculopathy is the opposite. It starts later, but the risk increases with the increased time. Like the prevalence in the first year is like 5 to 8%, and then after at 10 years, the risk is like 50%, half of the patients. It's considered a factor for both short-term and long-term mortality. It could be, so what happens is there is some intimal proliferation and wall thickening of the vessel from that vasculopathy. It could be diffuse concentric thickening, or it could affect just the middle and distal segments or the side branches. But it could be diffuse, but also can be focal eccentric lesions in the epicardial arteries. The presence of coronary artery calcifications on the CT calcium score relates to the presence of allograft vasculopathy, and it's a strong predictor for future cardiac events. But the negative coronary calcium score does not preclude vasculopathy, like in most patients, non-transplant patients. And like keep in mind that transplanted heart is denervated, and symptoms of myocardial ischemia may not be typical and usually absent. This is a patient with inferoseptal infarct and a focal area of dark signal of no reflow. They graded the vasculopathy into 4 grades. Grade 0, there is no disease. Grade 1, when there is mild disease. Mild disease is when the left main is less than 50%, or when the LAD, circumflex, and RCA, the major epicardial vessels are less than 70% lumen narrowing. Grade 3, which is the severe, is when the left main is more than 50% stenosis, or more than 2 primary vessels, more than 70% stenosis, or if it is grade 1 or 2 and plus the allograft dysfunction. And the intermediate grade is in between. It's when the left main is less than 50, single primary vessel more than 70% stenosis, or branch stenosis more than 70% in 2 systems. This is in between. But in grade 1 and grade 2, there is a normal allograft function. But in grade 3, any grade with allograft dysfunction, LVEF less than 45, this is considered grade 3 or severe. This is a patient with akinetic segment at the inferoseptal wall and focal signal abnormality at the same time. And this is the resting perfusion image, and there is a perfusion defect at that a focal area of akinetic segment with perfusion defect along the infrareceptal wall. And this is the LGE images, and it shows that hyperenhancement, delayed gadolinium enhancement in the infrareceptal wall with the focal dark signal of no reflow here. Additionally, there is a focal area of non-infarct territory. It's patchy, it's along the anteroceptal wall, subepicardial to mid-myocardial pattern. So this is an example of infarct and another focal area of non-specific enhancement along the anteroceptal wall near the RV insertion site. And this is, the study was done and published in Radiology to evaluate for the vasculopathy by coronary CTA. And they concluded that it is excellent in negative predictive value for the use of the diagnostic, for the diagnosis of vasculopathy. This is an example of a case with the angio. It can be really challenging on angio. There is complete flow through the LAD, but at the same time, there is diffuse wall thickening of the LAD that compatible with vasculopathy at the same patient. And this is an example of when the lesion is just focal, causing focal stenosis of the large obtuse marginal branch, and it is just focal stenosis by the wall thickening. And it correlates with the lesion seen in the on the angio study. So despite those patients are not receiving metoprolol or beta blockers to control the heart rate, still nowadays scanners are really fast. They can the study can be tailored to retrospective gating and can generate really good images in terms of evaluation of the arteries. The presence of LGE correlate with the severity with the vasculopathy. So that goes back that LGE correlate with the bad, more LGE, the worse the prognosis. And one of them that it correlate with severe vasculopathy, allograft vasculopathy. And cardiac MRI stress perfusion, I think it will be having a rising role in the future in detecting microvascular disease, because the vasculopathy can affect the epicardial vessels, and at the same time, it's the microvessels. And this is an example of a perfusion defect on stress cardiac MRI that shows the defect along the lateral wall and inferior wall suggestive of ischemia. So it can affect the epicardial vessels and microvessels. And there will be, we are facing multiple modalities and for evaluation of the cardiac allograft vasculopathy, angiography, the intravascular ultrasound, the CT calcium score. But remember, in those patients with heart transplant, can be, if the calcifications are absent, this does not mean that the patient does not have vasculopathy. Coronary CTA at that time can be valuable to detect the wall thickening, either diffuse or focal. Cardiac MRI, there is a rising role for the cardiac MRI perfusion in evaluation of those patients. Stress echo nuclear studies can be also used. The Heart-Lung Transplant Society put some recommendations about the angio recommendation as class 8-1, but it is limited to the epicardial vessels. The intravascular ultrasound is very nice evaluation, but highly prognostic, high tissue penetration, can see the arterial wall very nicely. It is classified as 2A recommendation. Stress echocardiography, it's available, but it's depending on the acoustic window availability, and can evaluate the cardiac structure, function, wall motion abnormality. The cardiac MRI was not included in that society recommendations, but I think, but the high resting heart rates nowadays, there are some sequences. If we are facing the higher heart rates, we can do these rapid sequences. Cardiac devices is really not an issue these days, and challenging perfusion quantification software is a challenge, but there is a rising role for the MR stress perfusion in those patients. Those patients also are at some of those patients have some kidney dysfunction. That's why the GFR may be a challenge, but with a like NSF risk, but it's a very minimal risk. The cardiac coronary CTAs, they put it as a classified 2B, and the limitation is the high resting heart rates, but we can tailor that by the retrospective study. Radiation exposure, I think it's a risk versus benefit issue. And again, the contrast allergy, contrast nephropathy are other risks. Just remember, there are other complications for the heart transplant process, like detection, immediate post-surgical complications like hematomas or anastomotic leaks. And what's mostly can be referred for cardiac MRI is to evaluate if there is complication of pericardial constriction, which it can be manifested as thickening of the pericardium, septal bands during the cardiac cycle. Like here you have the leftward deviation of the interventricular septum during diastole, and then bowing of the, again, like rightward movement at the end of the diastole or early systole. And that's what we talked about, like expected post-transplant anatomic and structural features. We touched base about rejection and vasculopathy, and we shared some cases. Thank you very much. And the summary will be that, and of that talk, that T2 is highest diagnostic accuracy, followed by T1 and ECV values. Particularly, the multi-parametric use is helpful in those patients. LGE was not associated with strong diagnostic performance for detection of rejection, but carries important prognostic information. The multi-parametric assessment are highly producible and are reliable in detecting acute cellular rejection. And thank you very much. I'm open to questions.
Thank you so much for a really wonderful overview of complex patient population, but one where the stakes are very high. I'll open it up for questions for Dr. Fadl. Go ahead. Yeah.
Good morning. Thank you, Shaimaa, for the great talk. This is a question for you and for those who are on the call and they have experience with this. We have a gentleman in the hospital currently, and he had a heart transplant, I would say about a month ago, or maybe more, but it's pretty recent. And he has a pericardial effusion, slightly increasing, associated with pericardial thickening. But what is perplexing about the effusion is that it has this onion skin appearance, hyperdense content. Now, if somebody's acutely bleeding on a non-contrast CT, we see hyperdensity, which means fresh blood. However, this gentleman has been looking like that for weeks now. And the chances that this means that he has acute bleeding is little, because he would not have survived it, most likely. And I was thinking, okay, is this just older blood? Is this some sort of infection that is looking like that? Is this somehow hyperdense material got into pericardial space that is less likely? But I can't really find a convincing answer for that. And because technically bleeding or oozing is still on the table, it's hard to also ignore it. Not to say that looks like we have increasing, excuse me, tubulation. Now, we had an echo like about 3 or 4 weeks back, and that was negative for hemodynamic effect. I am not sure if that's the case now, because clearly the heart, the ventricles are becoming more and more hypoplastic, which means that there is a constrictive effect. So is there anything that justifies why we have this hyperdense component within the pericardial space? And what should be done? Should we proceed to another study, maybe contrast CT or MR? And if you have seen cases like that.
So,
I think,
um,
Leila, you have a great valid point. Yeah, go ahead, Corey, you wanted to say something?
Oh, no, I was just gonna say, as a plug, we've got a case sharing day in 2 weeks. Maybe we could drop it in the folder and, let people see the images and weigh in. I know he's in the hospital now. We can sort of have an internal discussion, unless you have any thoughts right off the bat, Shaimaa, about what this sounds like it could be.
Yeah, it comes to my mind also the same thing that we see with CAPG or other cardiac surgeries, that sometimes patients may bleed a little bit and cause some irritation of the pericardium, fibrinous reaction over time. And that fibrinous inflammation of the pericardium will appear like a little bit thickened pericardium and enhancement and constrictive pathophysiology. But I agree with you, like cardiac MRIs can tell us like if there's constriction or not at this stage, if this is persistent pericardial thickening. But maybe you are correct that the patient bled at some point and it caused some irritation or inflammation of the pericardium and fibrinous reaction.
Okay.
Do we
I've
do
got
the I'm sorry, go.
no,
I
go
have
ahead,
a
Shaimaa.
question. Do we do the intravascular ultrasound here?
Yes. They
Okay.
do it in the cath lab. I'm not sure, Dr. Cook sometimes is our go-to interventionalist, who of course is also a heart failure attending. And so he does a lot of those coronary angiograms. And I'm not sure exactly when he decides to deploy IVUS or not, but yeah, they certainly have the capability and they use it.
Because from the literature, it meant like in vasculopathy, it meant I felt that this is like a gold standard or the most accurate test for the diagnosis, but I don't know how frequent we do it and if we do it or not. Yes.
Yeah, rather than a fluoroscopic sort of luminogram, they can look at the different layers. I had a question, Shaimaa. So, a lot of these patients receive their transplants and then they need epicardial pacing wires, and sometimes they're clipped and retained. We can't scan those patients, can we?
Those patients with temporary epicardial wires, we are scanning those patients. We hardly now refuse any, like we altered the policy right now that we don't refuse any of those patients anymore. We didn't have any incidents so far. So we scan patients with epicardial leads, but most of these patients have temporary epicardial wires, which does not affect really the magnetic trends or field that much, like does not cause artifacts, that much artifacts. You hardly know that they are present on the MR if those are the temporary epicardial wires.
Great. I didn't realize that we'd actually shifted our official policy over that. That's wonderful because yeah, that
Still,
tends to
it's
come
back and
up.
forth, but like it's back and forth. But we wanted even to eliminate that the radiologists need to check the chest X-rays. But so far, we are in the process that we are scanning those patients anyway. We didn't have any events with those.
Excellent. Any other questions for Dr. Fadl from the group? All right, well, we'll go ahead and close the session. Thank you again, Shaimaa. This is a really wonderful talk, and thanks everybody for attending, and we'll see you all back next week.
Yes,
Thank you.
thanks.
Thank you, Dr. Grazer.
Sure.
Thank you, everyone.